Okay, everybody, welcome back. This is part 5 of your neurological emergencies. We're going to start talking about seizures here, the different types of seizures. Definition of a seizure is a neurologic episode caused by a surge of electrical activity in the brain. It can usually takes the form of convulsions and or can be associated with a temporary alteration in consciousness. Okay, and there are basically two different groups: generalized seizures and what we call partial or focal. You're going to hear those kind of two terms be kind of thrown around. They both mean the same thing: a partial or a focal seizure. We'll talk about those individually in the next couple slides. So when we're talking about a generalized seizure, there's really nothing general about it, but it's a result of abnormal electrical discharges from large areas of the brain. It can be characterized typically by sudden loss of unconsciousness and a generalized severe twitching of all the muscles that can last several minutes or possibly even longer. And really, it can even last a couple seconds. But it is usually some form of altermentation and some form of seizure activity in the actual body itself. And it can be as simple as just a brief loss of consciousness or a lapse of consciousness. And we're going to talk about that here in a second. And a generalized seizure can just have that where it does not involve any changes in the actual motor activity of the patient. When we're talking about partial seizures, people can actually have simple partial seizures that actually do not change their level of consciousness. It can appear as numbness or weakness, possible dizziness, possible visual changes, or some sort of unusual smell or taste. And that's kind of the big one with the partial seizures, is the unusual smell or taste. It's also known as an aura. We're going to talk about auras here in a sec, but some people with seizure disorders can actually feel their seizures coming on because they smell something. And a lot of people say it can smell like coal or like brimstone, or they smell or they taste some kind of like metallic substance in their mouth, and it's kind of it's kind of the body's clue that this patient is about to have a seizure. Not all patients that have seizures have auras, though. Okay, and with the partial seizure, specifically the simple partial seizure, they may have some twitching or probably a brief moment of paralysis. When we're talking about the complex partial seizure, this is the seizure that does have altermentation. And again, it's results of abnormal discharge, usually from the temporal lobe of the brain. And they get some really weird kind of motor stuff that goes on with them. They can actually start to lip smack. And lip smacking is basically kind of opening and closing their mouths continually and smacking their lips together. They can have unusual eye blinking. They could just be blinking their right eye, they could just be blinking their left eye, or they can do any combination of the two. And they could also have this isolated kind of jerks. It looks just like kind of twitches, but it's just like a jerking motion in some of their joints. People that have complex partial seizures usually describe some kind of unpleasant smell associated with them, and those smells can vary from numerous different things. They could describe visual hallucinations. They see things that other people aren't seeing. Some kind of uncontrollable fear that all of a sudden they kind of get freaked out and they're actually having a seizure when they look like they're having almost a panic attack or some kind of sympathetic response, or any kind of repetitive physical behavior. One of my favorite patients of all times, he was an awesome dude. He had some significant brain tumors, and he used to have some pretty wicked seizures, and unfortunately he ended up passing away. But young guy, real young guy. I think he passed away. I think he was 42 when he passed away. Just a damn shame, man. This guy was so cool. Anyways, he used to beat his chest like a gorilla with one hand. That was his repetitive physical behavior. And he'd go into some pretty wicked seizures, and he'd start with beating his chest, and he wouldn't know that he was doing it. He'd literally be sitting there talking to you, making eye contact, and all of a sudden his arm just kind of comes up and he starts beating his chest, and it starts getting faster and faster and faster, and next thing you know, he's in a full-blown generalized tonic-clonic seizure. So again, something that we really do not understand what is going on. We understand that this is a abnormal discharge of electrical activities in people's brains, but there could be numerous causes of this, and some people just have seizures where they've been diagnosed with seizures from an unknown etiology, right? They just don't know why people have seizures. So some patients experience what's called an aura prior to having a seizure. It could be a smell, it could be a taste, it could be some sort of visual change, it could be some sort of hallucination, and this is kind of their way of, people that actually are able to experience an aura. One of my patients that that I knew, that I ran on many times, he'd be out shopping in wherever, Walmart or Lowe's or wherever the hell he was at, and he'd develop this aura. And he would literally lay himself down on the ground in order for him to have the seizure, so that he wasn't standing and walking when he had his seizure and possibly fall down and injure one of his parts. He would lay down right then and there. He'd call 911. He'd tell the emergency dispatcher, "Hey, I believe I have a seizure coming on," and we would go to wherever he was at, and more than likely he would be seizing when we got there. But he would develop an aura. And again, I want you guys to remember that not all people that suffer from seizures get auras, okay? Patients with a history of seizures recognize their auras and usually take steps to minimize the injury. And auras do not occur prior to every seizure. Not all patients with a seizure disorder experience an aura. Please remember that. Going back to generalized seizures, it's characterized by a sudden loss of consciousness, chaotic muscle movement and tone, and apnea. Apnea means that the patient stops breathing while they are seizing, okay? We're going to talk about that here in a sec as well. May exhibit bilateral muscle movements characterized by a cycle of muscle rigidity and relaxation. These can usually last 1 to 3 minutes. If it's a serious seizure disorder, they can last 5 to 10 minutes. I've heard of patients lasting 20, 40 minutes seizing. And those are usually people that are wheelchair bound. They've had significant seizures over their lifetime, that they are not functioning accordingly with everyday normal society. And again, you guys know how I feel about the word normal. I hate the word normal. What is normal? Everyone has a different definition of that, but usually the generalized seizure is the more problematic seizure. Generalized seizures, also known as tonic-clonic seizures or grand mal seizures. And I have a picture of what tonic-clonic is coming up here in a sec. They could have the possible aura. They usually have the generalized convulsions. They are going to have a loss of consciousness. They can have a loss of bowel and bladder. Okay, these people can poop themselves. They can pee themselves. They could be incontinent to that stuff. They could be cyanotic, or have what's called a dusky appearance, almost like this grayish color appearance to their skin, and that's due to hypoxia. Okay, that's due to the fact that they haven't been breathing for the last 3 to 5 minutes, or for the duration of their seizure. And that postictal state again is where it's a period that the brain is actually trying to reset, where they're gradually kind of coming back to a normal ANO times 4 level of consciousness. That can take some time. And what we do as providers to help them with that is we try to give them a little bit of oxygen after they're done with the seizure activity, a little bit of oxygen just to try to get to the brain and try to clear up some cobwebs from them actually going into the seizure. That usually kind of helps the postictal states out a little bit. But most people, once they come out of a seizure, like I said, they can be combative with you. They don't want anything to do with you. Sometimes it's hard to actually apply oxygen to that person. So we usually try to do like a blow-by oxygen, right? We might hook up that non-rebreather, not necessarily put it over the patient's face, but we try to keep it as close to their mouth and nose as possible, so at least they're breathing in some more pure oxygen or some higher concentration than the atmosphere around them. So this is the tonic phase and the clonic phase of a tonic-clonic seizure. The tonic phase is kind of a severe hyperextension of the actual back and all the joints. However, the arms actually come in closer to the core, where the clonic is a relaxation phase of the core and the lower extremities, but the arms are hyperextended out, and you can see based on this picture, we also tried to show the cyanosis, or that grayish color appearance to this little guy's face there. So there's some good videos online if you guys have never seen a patient with tonic-clonic movement, or seen a patient actually have a seizure. The first time you see it, it's going to be a little scary for you guys, right? And every seizure kind of presents differently. We want to make sure that we are protecting the patient as best as possible while they are seizing. We're not going to hold them down. We're not going to give them a bite block or anything like that. We're going to let them seize. Okay, we just want to make sure that the area around them is clear, so that they don't bump into like a nightstand and a lamp fall onto them while they're seizing. We're going to let them seize. We're going to let them do their thing. We are going to continue to talk to our patients. I'm going to say that again. We are going to continue to talk to your patients. Okay? We don't know what's going on with seizures. Some people say they can hear everything around them. Some people say they can't. Either way, we're going to talk to our patients and let them know that we're here to help them, that we're going to do everything in our power to help them, and that they are having a seizure, that they are experiencing a seizure, and that we're not going to hold them down. We're not going to give them a bite block. We're not going to put anything in their mouth, really, until they come out of the seizure. Absent seizures are kind of interesting. We actually used to call them petit mal seizures. We stopped calling that a while back, but they were known as petit mal seizures, kind of not as grand as the grand mal, right? But absent seizures are actually, they can last for a couple seconds, and they're usually kind of very interesting in their presentation. You could be sitting there, somebody with a history of absent seizures, you could be sitting there talking to them, they might be answering your question, all of a sudden they stop, and it's almost like they start to daydream for a sec, right? Or a couple seconds. And then all of a sudden they look you right back in the eye and they continue the conversation they're having with you. Kind of weird to see. But really it's just like as if the patient happens to just be daydreaming in complete thought, right? It's kind of weird. And really it's just it's a full recovery. There's really not much of a postictal stage to this. They just have this brief lapse of memory, and then they come right back to. And then we do have people that suffer from status epilepticus, or an epileptic patient. These are patients that have been diagnosed with seizure disorders. These are usually patients that has, or anybody, even anybody that has seizures. As soon as they have seizures that start lasting longer than 5 minutes, more than likely they will be diagnosed as an epileptic. This could be patients that have back-to-back seizures. So they seize, they have this little postictal period, and then they go right back into a seizure. So back-to-back seizures is known as status epilepticus, or status seizures. Okay, seizures that continue every few minutes without the person regaining consciousness, or that last longer than 30 minutes is known as status epilepticus. Guys, that's a 30-minute seizure. That could be a 30-minute seizure of full tonic-clonic activity, and the patient might not be breathing. Talk about an enormous amount of cell damage to the brain. These people usually end up in wheelchairs. They more than likely are very developmentally delayed, and they're basically prisoners in their own body. And for whatever reason, they just keep having seizures and seizures and seizures, and their seizures last very, very long. This is just a list of some more common seizure medications. I have had reports from some of my past basic students that the National Registry has some kind of scenarios that mention these drugs, and it's really kind of keywords. We've talked about that for the National Registry. Keywords on the test that can actually help you answer the questions. So some of the more common ones is Keppra and Dilantin. There's also phenobarbital is a good one. Depakote, Topamax, Klonopin. You guys can look over those. Don't worry about committing these to memory, but I would definitely kind of highlight this slide and make sure that you guys look at the names of these medications before you guys go in and take the National Registry. Guys, I skipped ahead a couple slides. You guys can read over those. It's basically kind of explaining a little bit more that you guys found in that chart for the causes of the seizures. However, we're going to talk about febrile seizures, and this is a call that we do get called out to a lot. This is caused by a fever. About 5% of children experience febrile seizures anywhere from 6 months to 6 years old, and they're finding out that this can run in families, and we have no clue why. Okay, basically what happens with a febrile seizure is kids, specifically neonates or babies, their brain is not fully developed. They cannot control their temperature as good as we can, okay, because they have such an underdeveloped brain. So they're really not able to control their temperature. And here's the problem, specifically for new mothers. And I'm not, look, I have a lot of respect for women. I think you guys are a very complex and interesting species. You guys take a lot of grunt, right? You guys are the baby makers. So, we just kind of, help support you guys through all this and whatnot. But when you guys do have kids and your kids get sick, you guys love to bundle them up, right? Let's try to keep them nice and warm, and we cannot thermoregulate that young. So we have a patient, let's say this little guy on the screen here, starts off with a temperature of 99. Mom gets kind of worried. Oh, he looks like he might be chilled. Maybe she starts seeing some goosebumps kind of pop up on his chest or whatnot. And she swaddles him up in every single blanket, gives him a big old onesie first, right? Swaddles him up in the blankets and holds him real close to her chest to keep him warm. Well, all of a sudden, it's a significant spike in temperature. And I'm talking like you go from 99 to like 103 on the drop of a dime, instantly. That's going to cause you to have a seizure. That's what's going to cause this little dude on the screen to have a seizure. So you guys are going to get called out, and more than likely your patient is going to have stopped seizing when you guys get there. However, this patient is still all bundled up in like 4 or 5 different blankets that they've been swaddled in. They might be wearing a onesie. It might look like the kid from the Christmas Story, right? All bundled up in his big ass jacket. He can't even move his arms, right? The one thing that we need to do to cure this is get this kid out of the swaddle. Let's expose the kid to the outside air. All right, let's take off all the swaddles. Let's undo the onesie. If we have to, let's pull off the diaper and let this kid run wild naked for a little bit. Okay, we need to have this kid be able to escape the heat of the fever, or they're going to keep on seizing and seizing and seizing. Okay, so for those of you guys that are out there that does not have kids, if your kid's having a fever, it's okay for them to run that fever. It's actually healthy for them to run that fever. And then you guys want to switch off between Tylenol every 6 hours and ibuprofen every 6 hours. So it's basically going to be Tylenol, and then 3 hours later they get ibuprofen, and then 3 hours later they get Tylenol, and then 3 hours later they get ibuprofen. And we're going to keep doing this in order to keep that seizure under control. And the first time that you guys run a febrile seizure out in the streets, you're going to hear your medic tell the exact same thing to that new mom. Again, if mom wants them transported to the hospital, we will take them to the hospital, but it's technically not really necessary with a febrile seizure. We just got to do a little education to the parents and make sure that that kid does not get too hot again. So why is it important to recognize the seizures? Because your patient is not breathing while they are seizing. Okay, they're going to turn cyanotic, right? They prevent the patient from breathing. Now, not all seizures stops people from breathing, okay? But the majority of them, 95%, most of the time, those people are not breathing during the seizure, okay? If the patient has diabetes, we need to make sure that their sugars are okay. All right, I can carry every drug on the face of the planet in order to help me combat a seizure as a paramedic. And if the reason why the patient is seizing because their sugar, this patient needs sugar. The only thing that's going to stop the seizure is the sugar. And we're going to talk about diabetic seizures later on in the endocrine lecture. Okay, but yes, we want to recognize the seizure. And guys, there are some people out there that are very good at faking seizures. Okay. There are some people out there that are not so good at faking seizures. The people that are talking to you while they are seizing are not seizing, okay? I love those ones, right? They'll be sitting there talking to you, going into full tonic-clonic motions, right? And they're sitting there talking to you, answering your questions appropriately. They are not seizing, right? They might be after some kind of drug, right? Maybe they're hooked on benzos, which is the drug that paramedics give to kind of stop the seizure activity, or whatever, right? Who the hell knows what goes on in some people's heads, okay? But yeah, there are some people out there that do a very good job at faking a seizure. And again, it's just we want to make sure that you guys will get duped. It's going to happen. I've been duped plenty of times, right? Every paramedic's been duped by a fake seizure. You know, we just want to try to do our best and make sure that for the people that are truly seizing, that we are providing good care for that patient when we are in contact with them. The other thing we want to check on our seizure patients is make sure that there's no associated trauma. Maybe they were walking when they had a seizure, right? Hopefully they weren't driving, but that could be the cause of the car accident. You know, somebody that has a seizure disorder, that's not supposed to be driving, you know, hey, they got to get to point A and point B just like the rest of us, right? They got to hold a job down just like the rest of us. And sometimes they hop behind the wheel and they get into a car accident. Hopefully they didn't hurt themselves. Hopefully they didn't hurt other people, right? And then, of course, we always need to check for incontinence. We need to check to see if they've peed themselves, if they've peed their pants, or if they've pooped their pants or whatnot. And then we need to offer to help them clean up. Right? That's, first of all, look, you know, I don't know. I don't know when the last time you guys wore a diaper. It's been years for me. But I'll tell you, you know, raising 3 kids and having to change diapers, it doesn't look comfortable when somebody is sitting in their own poop, right? It doesn't look comfortable when somebody um, is um, is sitting in their own urine. Okay, we are patient advocates, guys. Okay, and yeah, there's going to be some times where you guys are going to have to get on scene and help somebody wipe their ass. All right, and just put yourselves in that patient's shoes. Okay, do you want to sit in your shit the whole time all the way to the hospital from point A to point B and then possibly have to wait in the triage area while you're sitting in your own shit? I mean, think about it. These people might not necessarily be seen by a doc as soon as you guys walk in the door. They could be waiting 3 or 4 hours in order to see a doc. Let's tell the nursing staff when we get there, hey, this guy has feces in his pants. Is there any way we can get some kind of new garment for them? Okay, just try to be patient advocates. This is embarrassing for these people. It's a condition that they have to live with. They've probably done it before. They're more than likely going to do it again. Okay, let's try to help them out. Okay, and just a little bit of information on the actual postictal state itself. So after a seizure, all the muscles relax. They just burned a metric shit ton of energy. Okay, we definitely want to check a sugar on these patients. We definitely want to check their blood pressure and their oxygen stats. We want to do a full set of vital signs. Okay, but we want to make sure that we're bringing up that blood glucose level check a little bit higher in our management, because if they did suffer a full tonic-clonic seizure, they used a ton of energy. We need to make sure that those sugars are good, because if they get too low, we can go right back into a seizure. Okay, so they almost become flaccid, right? Their breathing becomes a little bit labored because they're trying to catch up. They're trying to blow off all this excess acid, excess CO2, because they've been holding their breath for the last 1 to 5 minutes. Okay, so breathing patterns help the body balance the acidity in the bloodstream, and then with normal circulation and liver function, all right, so if they have normal circulation, they have a good healthy liver, the patient will begin to breathe normally within a couple minutes. But make sure that we're helping them out. Let's try to provide at least some blow-by oxygen in order to help kind of speed this process up for our patients. These people will be somewhat confused during the prostictal state. Okay, they could have a little small period of when they can have some kind of paralysis, and it could be mimicking a stroke. All right, they could become combative. All right, their brain has just been without oxygen for a little bit. They could be pretty pissed off at that. Okay, we need to be prepared for these circumstances. Okay, they might come out of this postictal state, or they might be in this postictal state, and they want to fight you. All right, just use your therapeutic communication, guys. Obviously, don't get hurt. Don't put yourself in harm's way. If the patient wants to take a swing at you and they appear to be intoxicated, let's just see if we can try to make sure that they don't go head first into a window or something like that. Okay, if the patient's does not, if the patient's condition does not improve, within a reasonable amount of time, we're talking 10 minutes, they should be pretty close to getting out of that postictal phase. Once we start going into that 10 to 20 minute mark, or 20 plus minutes, we need to really start considering hypoglycemia, making sure that we're checking their blood sugar levels and make sure that their BGL is within normal range, or we could have the possibility of some kind of infection going on. Either way, we have to ask about possible changes in medication. Have they had a change in their seizure medication? Has their doctor raised their milligrams? Has the doctor decreased some milligrams? Are they taking their medications like they're supposed to? Do they have access to their medications? This is stuff that we need to ask. And if they are having problems with their medications, we do need to get them to the hospital. They need to get some blood work. They need to make sure that that medication still is within that therapeutic range in their system, or they might need to be put on some other kind of medication in order to help their seizures. But really, some people have seizure disorders and they don't want to go to the hospital. And as long as they are A&O times 4 and they're able to answer the person, place, time, and events, we are not in the business of kidnapping. We might want to ensure that there's somebody there to watch them, but we can't force these people to go to the hospital. We can advise all we want. We could try to advocate for our patients, but if they don't want to go, they don't want to go. Okay, so Tylenol is the big treatment for febrile seizures. Make sure you guys look over your doses and your indications. Okay, specifically for this test coming up, I am going to also post up the other slide coming up, which is the exact same slide that you guys will find in your pharmacology PowerPoint on acetaminophen. We'll go over a couple things real quick. So here is the exact same slide that's found in your pharmacology PowerPoints. You guys need to know everything on this, okay? For your pharmacology exam, remember that your pharmacology exam is 100% fill in the blank. Specifically the drug interactions, the contraindications, why we're giving it, the class of drugs, everything on this slide you guys need to know. I'm going to skip ahead a couple slides. The next couple slides kind of talks about Tylenol and how to do the math for Tylenol. I'm going to skip ahead of that. You guys can read that for yourselves, and if you guys have any questions on the math, please make sure you guys email me so we can set up some office hours and I can sit down with you guys and go over the math with you.